So let's start. You see here when I show you this PDF of an article that has been published first 7 years ago, and then there was an update 3 or 4 years ago. This is about how to program the defibrillators. And this kind of manuscript does not exist for the pacemakers, but there is a consensus about how to program the ICDs. And what is really different is that you have parameters to program different according to the company. So here, what you see here is what is recommended for Medtronic ICDs. So in terms of brady, in terms of detection, in terms of therapies, and in terms of SVT discriminators. Of course, in the same manuscript, you have the same for example, here, it's going to be Boston Scientific. Okay, and
Je m'en charge.
Okay, and what you need to know is that really the manufacturer where the guidelines are different compared to the other is Medtronic. And I will try to explain to you today why there are such differences. And I think that's the way you will detect, and the counters is probably one of the main reasons why.
J'ai du mal à entendre.
You see here the detection. This is clearly different. So you see here these guidelines. I don't know if you know this manuscript, this article. The first author is Bruce Wilkoff from the Cleveland Clinic. And you see there are parameters, for example, for the brady. But what is important and what we're going to discuss today is this. In patients with no VT history, so in primary prevention, or in patients where VT is known, so in secondary prevention, you see here the recommendation about the zone, and you see for all these patients, of course, you need to adapt about the characteristics of the patient, for sure. And these guidelines are dedicated to patients with heart failure, not, for example, for Brugada or hypertrophic cardiomyopathy. This has been designed for patients with ischemic or primitive cardiomyopathy. And you see that only one zone for the guidelines, only one zone in Medtronic, only one VF zone, up to a limit of 188 beats per minute, no VT zone, and monitor zone upon user discretion. And it's different, of course, if it's in secondary prevention. So the VT zone is only programmed if you are in secondary prevention with episode of ventricular tachycardia. Okay, so once more, here, only one zone in Medtronic, and if you compare, for example, with Boston, that's really different. Since in Boston, you will have two zones for the same patients, primary prevention. You see the zone here, one VT zone, 185 up to 250 beats per minute, and then one VF zone. So two zones for all the other competitors, and more, just one zone for Medtronic. And there are reasons for this specific programming in Medtronic devices. Something also which is important, you see the SVT discriminators. The limit here is 230 beats per minute. So in a patient in primary prevention, of course, you need to adapt once more to the characteristics of the patients. If the patient is in AV block, you will not, in complete AV block, you will not program the discriminators. But if not, then for all the patients implanted, you should give the possibility to discriminate the origin of the arrhythmia between atrial fibrillation and ventricular tachycardia, for example, up to 230 beats per minute. So here, if you program here, first things, you see that like this, the VF zone, 188 beats per minute. And if you want to discriminate up to 230 beats per minute, then you need to have the possibility to discriminate inside the VF zone. And Medtronic is the only manufacturer where this is possible. You can discriminate the origin of the arrhythmia also in the VT zone, but also in the VF zone. Okay, so if you can show us now the programmer. Yann Charton, are you there? And Can you listen to me and can you
Yes, I am. I'm sorry.
Yes, nice. So we'll start with these patients, okay?
Yes.
So we'll try to analyze step by step the tracing, and the idea today is to explain how works the different counters, and then to explain why you have the possibility and it's recommended to program only one VF zone. Okay, so what do you think? What is this first?
This is an arrhythmia episode, noted VF, and it's a tachogram. We see sinus. Yes, there is only one zone of treatment.
Okay, so this is the plot, and this I always start the analysis of an episode starting with the plot, because you have a global idea of the episodes, and also a global idea also of the programming of this patient. And as you say, this patient, there is only one VF zone. Yes, program up to limit of 280 milliseconds. Okay, just one zone here. Yes. Okay, you see the plot. You can have the information in interval, and if you click, you can also have in rate. But I think it's better to keep on with the intervals. So if you re-click on the intervals, okay, and then you have a global ID. So what would you say here?
I would say the beginning of the plot is sinus rhythm.
Probably normal sinus rhythm. So the intervals are more or less 900 beats, 900 milliseconds. Okay.
And then we have a rapid acceleration with a lot of cycles within the VF zone.
Yes, sudden acceleration. So, and you see all the dots inside the VF zone. This can be physiologic. This can be true. I will show you on the plot when there are problems of leads. You may have a false episode of ventricular fibrillation, but the aspect is globally different in case of lead dysfunction. But this looks like a real arrhythmia. Yep.
Yes, and the counters are completed and there is not a detection.
Yes, at this time, the counter probably of ventricular fibrillation. Of course, you will have to check with the EGM at one time, but you see here that the detection, yep.
And between this time and the shock with noted 34.5 joules, so yep. It's probably the condensator charging. And
yes, then the charge of the capacitors. Okay.
And then the episode is end.
Yes. What is the criterion for the end of the episode here?
I think it would be 8 spontaneous cycle. So
yes.
Consecutive.
Yes, 8 consecutive cycles classified either VS or VPACE. Okay. Yes. Slow cycles. Okay. So if you summarize, I would say that initially there is a normal rhythm. It seems to an acceleration inside the VF zone, detection, correct detection, and then a shock is delivered. And apparently the rate at the end is different than what you had initially before the arrhythmia. But at least there is a sudden change in the rate. Probably the shock has been efficient. Okay, so now if you click on the EGM, so once more, I would strongly recommend anytime you analyze the tracing in Medtronic list, I will start with the plots, okay, to have a global ID, and then I check with the EGM. Okay, so what are the channels here?
We have a RV tip to ring and a far field channel with CAN to coil.
Yep. So the first one on top is the bipolar channel, and then you have what we call the choke channel, which is exactly a far field signal between the CAN and RV coil. This looks like a little more than the bipolar, like an ECG. So it's there to understand the functioning of the device. Okay. So okay. Initially the tracing, and then what happens?
And then we have the very rapid and polymorphic arrhythmia starts.
Yes, acceleration of the rhythm. You see clearly it's really polymorphic. The cycles are initially they are classified VS because they are out of any tachycardia zone. And then remember there is only one zone. So the cycle will be classified either VS or FS. Okay. How do you classify FS? Why is this?
The cycle is noted F. It's analyzed the interval which is currently on the interval.
Yeah,
Interval en cours.
as you say, this in which company is this different?
It's in Abbott, for example.
In Abbott, here this cycle is classified FS because the interval, the current interval, is fast, and this is the only level of analysis, and it's the same for Boston, Microport, and Medtronic. When we'll study Abbott ICD, you will see that anytime you will have to make a relation between the current interval and the mean value of the 4 previous intervals. That's a specificity of Abbott. But here in Medtronic, just the analysis of the current interval. Then how does it work?
So it's a probabilist counting, and we can see there is, I think, 40 cycles, and on the 40 cycles, there has to be 75% classified as FS, and it would be 30. And then the episode is diagnosed like as VF.
Yeah. So as you say, and that's a very important particularity of Medtronic devices. The counters in the VF zone and the VT zone are working completely different. And that's a very important specificity of Medtronic devices. If you have to summarize the VF counter, the word will be, which word will you use?
Probabilist.
Yes, probabilistic, okay? It means that you required at least 75% of fast cycle. So I will show you after how you can program it, but you need to program, anytime the parameter will be 75%. You cannot change the percentage. You cannot ask for 80%, for 60%. It's going to be 75%. So it's going to be 9 out of 12, 12 out of 16, out of 18, 18 out of 24, and like this, 30 out of 40, okay? This is now the nominal programming. Initially, in the VF zone, the programming is programmed like this. It's 30 out of 40, okay? So here you have a perfect detection. So you have more or less 30 consecutive cycles. And then you see the marker FD. It means that there is a detection of an episode of VF. So what has happened at this time?
At this time, the capacitors will beginning their charging.
Yes, you will start the charge of the capacitors. You see here, VF. Okay,
and
because the first therapy will be defibrillation. So how do you explain that the cycles now are fast and are labeled VS?
Yeah, it's because when the capacitor are charging, it's noted like that, but it doesn't matter.
Yeah, as you say, that's something a bit different from the other competitors. Also, is that once you start the charge of the capacitors, even if the cycles are very fast, they will be labeled as VS. Okay, so you see the intervals are very short, so they should be labeled as VF. But remember that during the charge of the capacitors, all the time it's going to be VS. That's an old version. It was like this in the very first version of the defibrillators, because in the very first version of the defibrillators, once the defibrillator started the charge of the capacitors, then there was no analysis about if you are fast or not. Whatever, at this time in these old devices, you will go up to the end of the charge and then decide if you will shock or not. Okay, so that's why they were labeled VS, but it's the same now in the new ones. It's always labeled VS once you charge the capacitors. So then you will see the marker CE. What does it mean?
It means like the charge is ending, and
this is the end of the charge.
Yes, and there is a confirmation phase with you have to check if there is 2 rapid cycle and 5 cycle, and then deliver the shock on the second fast bit before the shock.
Yes, exactly. So this shock is considered as non-committed. It means that once you charge the capacitor, if there is a spontaneous reduction of the arrhythmia, then the shock will not be delivered. So it's non-committed. And one of the criterion is that at the end of the charge, he will analyze the next 5 cycles. And if there are at least 2 fast cycles, how you define fast cycle, there are details, but whatever. But you see here, after the charge, there is one cycle which is labeled VS, and then the second one. And then since the two first one are fast, it will deliver the shock on the second one, okay? But you understand, it will analyze the next 5, and it will require the shock to be delivered, you will require at least 2 fast cycles, okay? Since the 2 first ones are fast, then it delivers the shock on the second one. What happens there?
Then there is the shock, and we have arrhythmia reduction.
So first, after the shock.
Yes, there is a blanking.
Yeah, the duration of the blanking, whatever, the details are not important, but it's going to be 520 milliseconds. You see here, this is the blanking without any possibility of sensing. The idea is not to sense more or less the shock. You see the polarization of the shock. So for 520 milliseconds, no capacity of sensing at all. Remember also that after the shock, there is 1.2 seconds where the defibrillator cannot pace. Let's consider there is no VS after the shock. You will have to wait for 1.2 seconds before delivering ventricular pacing if required. So the blanking, and then what happens?
And then we have at least 8 spontaneous cycles.
Yes, these cycles are out of the zone, so they are in the VS zone. So these cycles are classified VS, and you see the marker termination because you have seen 8 consecutive cycles out of any tachycardia zone. Okay. And you see that probably I'm not sure that this is completely reduced. Of course, the patient is not anymore in ventricular fibrillation, but maybe that the shock has induced atrial fibrillation. Maybe that's a possibility. You see, it's quite fast, a bit irregular. I don't know. Maybe it's sinus tachycardia. It's also a possibility, but it's quite fast, and that may be atrial fibrillation. That's not infrequent, and particularly in single-lead ICDs, that shock induces atrial fibrillation. Okay? Any question? Nope. So if you click on the text, you see there is everything. I will not go too much into detail here, but you see the whole summary of the episode, what has been delivered, and all the things. Okay, so we're going to move to the next tracing. So it's the same patients, and there is a second episode here. What do you think?
So it's the same beginning.
Initially normal rhythm, and then
we have again a very many cycles in the VF zone, but maybe some of them are very, very fast, and I don't know if there is some of them at the blanking limit. I don't know.
No, I don't think so.
No? Okay, so it's a diagnosis of VF again, and there is shock.
Is the quality of sensing, according to you, perfect or not?
There is some of the cycles that are noted in the out of the VF zone, maybe because there is undersensing.
Yeah, that's the best way, I think, to easily diagnose if you have some cycles that have not been detected. You may see dots out of the VF zones, and this probably corresponds to some cycles that has been non-detected. So if there is one which is non-detected, the next one will be slow. Okay, so that's the best way. When I want to see rapidly if the detection has been correct or not, you see here that there has been a detection of the episode, so no problem. At the end, he will receive his electrical shock, but you see that at least some cycles are probably undersensed here. So what happens then?
And there is a first shock, and I think
maximal shock. You see,
yes. Yep. And it's not efficient, and there is again arrhythmia, and the redetection counters are on, and there is a second shock, but delivered while the patient is not in arrhythmia anymore, and it's because the second shock is committed, and there is no verification phase.
Yeah.
And
That's unexpected, I would say. The first shock is delivered while the patient is obviously in ventricular fibrillation, but the second one, surprising because there has been, after the first shock, a persistence of the arrhythmia, and then probably something happens, I don't know what, and then the second shock is delivered. We're going to have a look to the EGM and try to explain this. So once more, initially normal rhythm, and then acceleration, polymorphic tachycardia. Then the first counter is a probabilistic counter, 30 out of 40. And once it's filled, then detection of the episode, then chart of the capacitor. You see here that there is a little of undersensing. You see some long cycles. These are the ones where the dot was out of the VF zone. See? And you see that, okay. So after the sensing, there is a long cycle, and then the first shock will be delivered, end of charging, first fast cycle, second fast cycles, and then the shock is delivered, a blanking, and then what you have said, this is now the redetection counter. What is the word for redetection counter also?
It's probabilistic. Again.
It's also probabilistic, and it's always 75% of fast cycle. Okay, 75%. You can, of course, program it differently that for the initial shock, and usually we program less cycles. So if for the first shock, it's 30 out of 40. For the second shock, it's usually 9 out of 12 or 12 out of 16. You don't want to wait too much before delivering the second shock if the first shock has been inefficient. And as you have explained on the plots, there is a spontaneous reduction at one time. You see, maybe also, well, yes, there is a spontaneous reduction. But as you said, this second shock is committed. It means that you have delivered the first one. The first shock is inefficient. And of course, you will not systematically deliver a second shock. Then what starts is the redetection counter. So if the redetection counter is filled, then you will start the chart of the capacitor. And this is not something that you can program or deprogram. But if the redetection counter is filled, then the shock is committed. And at the end of the charge, even if the patient like this, it's very infrequent and what happens here, because most of the times, if the first shock has been inefficient, then there's not going to be any spontaneous reduction after 3, 4, 5 seconds. It's quite infrequent, this tracing, but you see that then this second shock is committed. And that's the same for number 2, number 3, number 4, number 5, and number 6. In Medtronic, you can only deliver 6 maximal shock, but at the end of the charge here, you will deliver. So at the end of the charge, it will open the details, you don't care, but a window of 900 milliseconds, and it will wait for spontaneous cycles in this window. If there is one spontaneous cycle, it will synchronize the shock like here on a spontaneous ventricular activation. If not, after 900 milliseconds, it will systematically deliver the shock. So remember, the first shock is non-committed, but number 2 to 6, then they are committed. Means that there is a redetection counter, but if it is filled, whatever happened then, it will deliver the shock. Okay, and after 1, 2, 3, 4, 5, 8, you will have the termination marker because this is the end of the episode. Okay, any question? So if you click now on parameters, the parameters, you see how it is programmed here. That's the traditional programming. You see one VF zone. The limit here is a bit higher. In the recommendation, it's 188 bits per minute or up to 200 bits per minute. But here it's programmed a bit higher. That's the traditional programming here. And if you can show me the redetection counter. Okay, you see here, it's 30 out of 40. And then for the redetection, well, once more, it's probabilistic. Once more, it's 75%. Yes, 9 out of 12 or 12 out of 16. I will not wait too much before recharging the capacitor if the first shock has been inefficient. So, as you have understand, in the VF zone, probabilistic counter, what you can program is the number of cycles, not the percentage. The percentage is always 75%. Okay, whatever the programming you will choose. Okay, any question on this? So what do you think here? Jan, you're still there?
Yes. So single chamber ICD with this time several zone with the VD zone, fast VT zone, and a VF zone.
Okay.
The beginning of the tracing is probably sinus rhythm, and we can see brutal acceleration within the first VD zone, which is very regular, which is okay for the diagnosis of VT. And then we have the detection, diagnosis of VT, and the first therapy is a burst, which is efficient.
You see, there is no delay in the VF zone. If there is an episode of VF and if the shock is delivered, then there is first detection, 30 out of 40, but then you will need to wait for, I don't know, 7-8 seconds, additional seconds, because you will need to charge the capacitors in a VF zone before delivering the shock. And it's different in the VT zone. After the detection, there is no charge of the capacitors for delivering a burst. So once you fill the counter in the VT zone, immediately you will treat. Okay, so I think this is the reason why I think we should program a longer zone of VT, because if not, you will treat much faster the VT than the VF. Okay. Yep. Okay, so a burst is delivered and seems to be efficient. So if you look at the tracing now, you see the marker TS. It means that it has been detected in the VT zone. And then after a certain number of cycles, VT detected, ATP is delivered, it's a burst, and it's efficient. Okay, if you had to define the VT counter in the Medtronic devices, with one word, what will be this word?
Consecutive.
Yes, that's the word which is very, very important. In the VT zone, you need consecutive cycles. And that's a particularity, very important particularity of Medtronic devices. It means that in the VT zone, you need to have consecutive cycles. It means that if, for example, here there is one cycle which is classified as VS, then the VT counter will be reset to 0. If there is one cycle which is classified as VF, so very fast, there will not be any impact on the VT counter. VF cycles will not implement the VT counter, but will not reset to 0, of course. But a cycle which is VS will reset the counter to 0. So you understand that's a very, 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 very important specificity of Medtronic devices. And that's the main reason why you cannot program in the other, like in the other competitors, a VT zone up to 230 or 240 or 250 beats per minute. If you program a VT counter in very fast arrhythmia, like 230 beats per minute, there is a huge risk that this arrhythmia may be a bit polymorphic. If there is a polymorphic arrhythmia, there is a huge risk of sometimes undersensing. So if you program a VT counter for any undersense signal, you will reset the counter to 0. So that's not a good idea. And clearly, this counter has not been designed to be programmed with very fast rhythm. Okay, so if you this is a patient with multiple episodes of atrial fibrillations. And you see here that initially there is clearly, so you see in blue, these are the dots for the atrial rhythm. And in purple, it's for the ventricular cycles. Okay, so initially there is a very fast atrial arrhythmia and a very irregular response at the level of the ventricle. This looks like a really conducted atrial fibrillations. And you see, if you look carefully, you see that initially there are many points out of the zones, okay? Out of the, I will never program the device like this, for example, in this example, but whatever. You see that these dots out of the VT zone, they will systematically reset the counter to 0. At one time, there is a stabilization of the arrhythmia at the level of the ventricle inside the VT zone. And that's why then you will feel the VT counter. And that's why then no shock is delivered, because now there is the discrimination of the arrhythmia. So if you click on the EGM, so you see initially 1, 2, 3, 4, 5, 6, 7, 8 cycles classified TS. No, but anytime there's going to be one VS, the VT counter will be reset to 0. So if you consider the VT counter, it's going to be 1, 2, 3, 4, 5, 6, 7, and VS 0. So anytime you will reset. So anytime there is a VS. So this counter has been designed for that, in fact. This is really, if you consider a Boston device or an Abbott device, the VT zone and VF zone the counter are the same. And it's not, they have not been designed to differentiate what is a VT, which is monomorphic and regular, and a VF, which is irregular. When you program the VT zone in the Boston and Abbott, it's just a question of rate. It's not a question to differentiate between something which is monomorphic, VT, and polymorphic, VF. That's the case for a Medtronic device. It means that the VT counter has been designed for the VT. So what I mean in VT is stable arrhythmia and fast arrhythmia. In the ventricular fibrillation, the VF counter has been designed to diagnose correctly an episode of polymorphic arrhythmia. Okay, and the idea also of this counter is to produce a first level of discrimination between atrial fibrillation and ventricular tachycardia. In most of the time, now, if you program in a VT zone 30 cycles, if there is an episode of atrial fibrillation, there is a huge chance that at least there is one long cycle. And if there is one long cycle, it will systematically reset the counter to 0. So this counter initially has been designed to be a first step of discrimination between atrial fibrillation and ventricular tachycardia. And I would strongly recommend to use this counter only to tachycardia with a limit of something like less than 200 beats per minute. I never use the VT counter for faster arrhythmia. Of course, sometimes you see VT with a rate of 210 beats per minute with very stable intervals. It will work, but remember that with this kind of arrhythmia, this kind of rate, you may see polymorphic arrhythmia, and then you should avoid to program, I think, VT counter for a rate faster than 200 beats per minute. And that's why, for example, you will program only one VF zone, and I will explain why. Okay, so in this patient, at one time, there is a stabilization inside the VT zone. So with all the cycles classified either TS or VF, okay, FS, and that's why then you will feel the counter. Remember that the FS do not implement the VT counter. And this is where, when it's written AF, this is then, once you have filled the counter, that you will have discrimination, and then the device will recognize atrial fibrillation and will not deliver the shock. But the counter is a very important first step to differentiate between atrial fibrillation and ventricular tachycardia. That's been designed for that, and not for being used in tachycardia faster than 200 beats per minute. Okay? Any question on this? Of course, that may be a limitation in some cases. You see here this example. This is a patient with dysplasia with many episodes of ventricular tachycardia. And in this patient, we wanted to treat him because his episodes of ventricular tachycardia were symptomatic. And you see here, there are 3 zones. Okay, we do not program the patient like this anymore, but 3 zones here. And you see that it's obviously a ventricular tachycardia. The ventricular rate is much faster than the atrial rate, but you see it's quite irregular at the level of the ventricle, and some cycles are detected inside the VT zone, but there are also some cycles out of the ventricular tachycardia zone. And in this case, you will see that that's the reason why there is quite a delay between the onset of the arrhythmia and the delivery of the therapy. If you look carefully, you see here, that's clearly a ventricular tachycardia. You see, faster rate at the level of the ventricle, slow rate at the level of the atrium. So no doubt, if you ask the defibrillator to discriminate between ventricular tachycardia and atrial fibrillation, of course, he will say this is a ventricular tachycardia because the ventricular rate is faster than the atrium. But you see that this cycle is out of the VT zone. And anytime there is one cycle classified VS, then you will reset systematically the counter to 0. So the VT counter 1, 2, 3, 4, 5, 0, 1, 2, 0, 1, 2, 0. So that's one of the limitations, of course, of this kind of counter. The important word is consecutive. And you see, if the rate is a bit irregular, you may have some cycle classified VS, or if there is undersensing, sometimes you will have some cycles classified VS, and it will systematically reset the counter to 0. At one time, there is a stabilization of the rhythm. You see here, still a VS, VS, and then here there is a stabilization, 1, 2, 2, 2, 2, 2 consecutive cycles, and after X consecutive cycles, you will detect and deliver. Okay, so once more, in Medtronic devices, the huge specificity is that the way works the counters are completely different in the VT zone and the VF. That's a bit the same in Biotronic devices. For all the other competitors, the way you count in the VT zone and the VF zone is the same. It's probabilistic both in VT and in VF. In Medtronic, that's different, and that's a huge difference. And that's why you cannot use, if you program high rates for your detection zone, like it is advised now, for example, up to a limit of 190 beats per minute, you cannot use the VT counter, because the VT counter can be used only for a tachycardia slower than 200 beats per minute. Okay, that's quite a rule that we try to applicate every day when we program this kind of devices. Are there any questions here? So this kind of programming was quite frequent, I would say 5 to 10 years ago. We do not program it anymore like that at all. But remember that you can program also a fast VT. So you can program 3 zones, VT, VF, and fast VT. So you can program a third additional zone, but there must be a reason for programming 3 zones better than 2 zones. And in most of the patients, I don't think this is useful to program 3 zones, and we will try to see why. So the fast VT, if you click on the EGM, here you see there is obviously a rhythm. Okay, you see here, up. So there is a tachycardia here, accelerations, and you see that the cycles are classified as TF with the dot after the F, you see. And I will not go too much into details, but remember, this is a programming where the fast VT is programmed via VF, and I will explain you the difference. And if you look at the 8 last cycles before the diagnosis, so you have filled the VF counter, and if you look at them, if you analyze the last 8 cycles, none of them are classified as FS, so ventricular fibrillation. So the diagnostic will be fast VT, and then the therapy that will be delivered will be the therapy of the fast VT. So if you click now on the parameters, I don't know if it's very clear what I have explained right now. You see, this is the way you can program it. So this is not the way we do program today, but I will try to explain how it works. When you program 3 zones, then you will have the possibility to program the fast VT. If you click on it, you have the choice between via VF or via VT. Okay, and that's something important. If you close, via VF and via VT, if you select via VF, it means that you will use the VF counter. So the way it is programmed here, that's a bit surprising, but it means that between 200 and 231, that's going to be the fast VT zone. And after 231 beats per minute, that's going to be the VF zone. But it means also that you will use the same VF counter up to the rate of 200 beats per minute. So in the fast VT, you will use the VF. So any cycle that will be labeled as VF or fast VT will implement the same VF counter. Okay, so you will use the same counter, and if it's programmed like that, you will require 18 out of 24 cycles that will be labeled either VF or fast VT. If you have 18 out of 24 cycles which are labeled fast VT or VF, then the VF counter will be filled. And as I've explained, you will then analyze the 8 last cycles between the detection. And if there is at least one VF cycle, then this is going to be an episode of VF, and then the therapy of the VF zone will be delivered. If all the 8 last cycles are fast VT, none of them are VF, then you will diagnose an episode of fast VT, and then the therapy of the fast VT zone will be delivered. I could spend a lot of time to explain why there is absolutely no sense. I don't understand how it is programmed here, because but I may not enough time. But if you now click on the parameters, the way we are programming today is the fast VT is off, the VT is off. Let's consider a patient is primary prevention. Then on VF, you can program, it's 200 bits per minute or 188, 30 out of 40, and then, as you say, if you click on it on ATP during charging, we're going to program before charging. So what does it mean here? If you program before charging, it means that in your VF zone, you may have 2 episodes of ATP for a single episode. It means that if you program before charging, if there is a diagnosis of VF, then you will deliver a first ATP. And then if this first ATP is inefficient, did not work, then you will start the charge of the capacitor, but you will also deliver a second ATP during charging. It means that in the VF zone, for one episode, you can deliver 2 ATP before delivering the shock. So you see, that's a possibility. That's a singularity of Medtronic devices. In all the other one, in the VF zone, you can only deliver 1 ATP. So in Medtronic, with a rate of 200 bits per minute like this, then you can deliver 2 episodes of ATP, okay? So that's a first specificity. So if you want to program another zone for, let's say, you could say, okay, I want to program it differently for a rate up to 200, up to 230 bits per minute. I will add a fast VT. The only reason for that is if you want to deliver more than 2 bursts, if you want to deliver 3 bursts or 4 bursts or 5 bursts. Because if you program a fast VT with via VF, you're going to use the same counter, a probabilistic counter. So there is no interest to program a second zone since you will use the same counter. Also something, if you click on parameters, on detection, you know, the SVT limit is another very important parameter. As I have explained, you're supposed to ask for discrimination up to a rate of 230 bits per minute. So if you click on, it's going to be 270 milliseconds. And once more, the SVT limit, the capacity to sense and to discriminate, is independent about your zone. It means that you can discriminate inside the VF zone. So if you want to program 200 bits per minute for the VF zone and program a SVT limit up to 230 bits per minute, it means that you will have the possibility to discriminate inside the VF zone. And that's the case in Medtronic devices. And that's the difference with all the other competitors where you cannot discriminate inside the VF zone. So remember that in the guidelines, it's recommended to discriminate up to 230 bits per minute. So if you program just one zone, one VF zone, that's a possibility. You can ask for discrimination inside the VF zone. So if you program it like this, you will use systematically the probabilistic counter. The probabilistic counters, it will work for very fast arrhythmia, but also for slower arrhythmia. If you program 188 bits per minute, the probabilistic counter will work perfectly. You will have the possibility, if you program before charging, to deliver two bursts, one before charging and then one during charging if the first one is inefficient. And you will also have the possibility to discriminate inside the VF zone. That's the reason why there is a specific programming for Medtronic devices, because you can discriminate in the VF zone, because you can deliver 2 IETP before charging, and because if you program high rate for the zones, I don't think it's a good idea to program the VT counter. I would strongly recommend just to program the probabilistic counter with the VF counter, okay, and not this one with consecutive cycles. I only use, and it's not very frequent in daily practice, in secondary prevention when I want to treat a ventricular tachycardia. And if there is clinical ventricular tachycardia with a rate, let's say, of 170 beats per minute, I know I have seen the patients with the arrhythmia, I will program a higher margin compared to the competitors. If you program a rate of ventricular tachycardia 160 beats per minute, if the tachycardia, clinical tachycardia 170 beats per minute, be careful that sometimes there is a bout of, even if the arrhythmia is perfectly regular, there may be a bit of irregularity in the detections of the cycles. And sometimes if you program a very limited margin, some cycle may be detected a bit late, and then the cycle will be classified as VS, and then you will systematically reset the counter to 0. So you will delay the delivering of the therapy. Okay, are there any questions? I will show you a last tracing up. This counter here, this is something that you cannot, this is called a combined counter. You cannot program it or deprogram it. If you program a VT zone, then this counter is on and you cannot deprogram it. As I have explained, a VF cycle will not implement the VT counter. And therefore, if there is an arrhythmia that will oscillate between the VT and the VF, since for the VF you require 75% of cycle inside the VF, if let's consider an arrhythmia just oscillating between the VT and the VF zone, and 50% of cycle inside the VT zone and 50% inside the VF zone, the VF counter will never be filled, in fact, because you require 75% of cycle inside the VF. So if there is an oscillation between VT and VF zone, 50% inside the VT zone, you will never fill the VF counter. And since the VF cycle do not implement the VT counter, there is going to be a long delay. You will need to wait a lot before filling the VT. And if there is an oscillation, probably that you want to treat like a VF, more like a VT. So there is one counter that you cannot deprogram, which is called a combined counter. I will not go too much into the details, but you see here, it's a bi-V pacing, and then initially it's FS, FS, FS. In any arrhythmia, after 6 cycles labeled FS, then we'll start the combined counter. You see here, then there is alternation here between VT, VF, VT, VF, VT, VF, VT, VF. And therefore, you do not feel, it's programmed with 30 out of 40. You do not feel the VF counter. And it will take a lot of time before filling the VT counter. But you see here that there is a marker FD. It means that there is detection of ventricular fibrillation. If you program 30 out of 40, the combined counter is automatically programmed at 35. It means that the device, after 8 FS cycles, 6 FS cycles, it will count both the VT and the VF cycles. And it will say, okay, 1, 2, 3, 4, 5, 6, 7. It will sum all the cycles labeled VT and VF. And if there is 35 cycles classified either VT or VF, so more than the VF counter, it's always more than the VF counter. If you program 30 out of 40 for the VF counter, then the combined counter will be 35. And then if there are 35 cycles, FS or TS, it will do exactly the same that for the fast VT. It will analyze the last 8 cycles. And if in these last 8 cycles before the detection, there is at least one cycle like here or here, which is labeled FS, then the diagnosis will be ventricular fibrillation. And then you will treat the episode like an episode of ventricular fibrillation. Is this clear for everyone? Because this is a limitation of these counters also, since the FS do not implement the VT counter, you will have to wait a lot if the VF counter is not initially filled, okay? And if there is alternation, you will never fill the VF counter, okay? So that's the way how to treat, like a ventricular fibrillation, an episode with oscillation between the VT zone and the VF zone. Okay, this is the combined counter. And once more, this is not something that you can readapt, reprogram, or deprogram. If you program 2 zones, VT and VF, this is going to be systematically on and you cannot deprogram it. Okay, any question? No, it's clear for everybody. Okay, so if there is no question, we will meet next week, and I think it's going to be also Medtronic. We're going to discuss about problem of oversensing and problems of discrimination. Okay, how does it work? The PR logic, how does it work? The wavelet and all this. Okay, so thank you very much. Have a nice day and see you next Monday. Bye.